Hi, welcome to this module on how healthcare is paid for. We'll explore major payment models and how they shape provider behavior and patient care. Payment isn't just financial, it influences clinical decision, system sustainability, and even patient satisfaction. Let's see how. It's very important that you need to understand that incentives drives behavior and behaviors will affect the outcomes. There are many types of payment system, payment models. Some are mixed, but let's make it simple. Let's focus on 5 models. Fee for service is essential. The more you use, the more you get paid for healthcare services. This is very common in all situations. For example, if you buy a plate of chicken rice and you buy more, then we discount. But ideally, the more you sell, the more you get paid. Next is capitation. Basically, capitation is a pre-agreed payment system where you decide how much you're going to get per participant. Okay, salary. This is also quite simple. Otherwise, I'm being paid a salary. But let's go into why salary is not the best way to pay healthcare providers. Bundle payment. Instead of paying piece rate, why not we bundle together everything and pay a certain amount for that? That is at the episode level. Finally, the more recent is actually value-based payment, pay by value. Some say pay by outcomes, some pay by performance, and so on. Number one, fee for service. I think fee for service is a good model if the problem is productivity. If the healthcare providers are not keen to do work beyond office hour, paying them by services will tend to incentivize people to work after hours, 24 hours, because of fee for service. That's the pro. Unfortunately, it may encourage overuse. As we kind of covered previously or in future, there's this problem of healthcare asymmetry, information asymmetry. So as a credence goods, you do not know how good the services is or whether you need the service at all. So with your fee for service, a few things, you need to have very strong guidelines so that healthcare providers don't over provide. You also need to have scheduled payment, meaning that a standardized fee so that everyone can pay that. That is for cost control. If you do not have fee guidelines, any predetermined fees, and you don't have any guidelines on what services can be provided, this will lead to cost escalation as seen by some of the developed countries. Capitation. Okay, this is probably something that is very disliked by providers because there's a lot of uncertainty in payment. However, from the payer point of view, this is amount I have budgeted and decide to pay. It helps to control cost because the provider has already agreed and therefore they need to take in the risk if there's over provision. So it also hopefully encourage prevention. Why this is so is because if they believe that prevention can reduce costly costs in future and there is a renewal, so it's not a once-off thing, you can actually promote prevention so that the patients will not develop conditions of which the payment will escalate beyond the predetermined fees. However, there's a risk of under provision because we do not know who will use, who will not use. There may be an incentive for providers to ration the care to prevent overuse. So capitation is scary, at least for the risk-taking point of view. So only need to have certain provision for exceptions. For example, if you have a very costly patient that is way beyond what is agreed on, do not use capitation. Otherwise, if I pay for that expensive patient, the rest of the patient will suffer because the fees are already predetermined. Salary model, this is quite common in a lot of employees. So what's the difference between employee and a contractor? Definitely usually stable. There's also a problem of reducing over treatment. Why? Because you're being paid for a certain number of hours. If you do more, then good luck to you. If you do less, then you're more incentivized to do it. but there may be a problem of having low productivity because there's no incentive for productivity. So if you do a salary model, you might consider having a hybrid model, include certain performance indicator. For example, the more you do, the more you get incentivized. But that goes back to a bit on fee for service. So that's always a problem. With a salary model, the risk is actually less because there's a guaranteed amount. So you can go back to capitation. Maybe you can have a guaranteed amount, and then there is a salary part, and some part of it is under capitated model where the cost is already covered, so the rest is just icing on the cake. Bundle payment, the good thing about bundle payment is you actually focus on not just inpatient care, outpatient care, community care, the whole spectrum, because what you're interested in is the full cycle. It helps coordination, hopefully efficiency. So for example, diagnostic rater group DRG, they actually focus on inpatient care. So everything is already well optimized. Unfortunately, it doesn't cover outpatient care because it's difficult to get data. Systems are not linked. So therefore, if you can think of it as an extended DRG, diagnostic rater group, that's some sort of a bundle payment. The problem is complex. Negotiation is difficult because now you need to get the inpatient people, talk to outpatient people, talk to rehab people, and they must all agree on the same amount. That's not so easy. So more and more, we're looking at integrated care. But when we talk about integrated care, we're talking about real integrated care, not having different profit centers. So if the inpatient and outpatient have different profit center, go back to square one, you are integrated by name, but not in function. Okay? Finally, value-based payment, it focus on outcomes, but question is it PRAM, patient reported outcome measure? Is it PROMS, patient reported outcome measure? Sorry, PRAM is patient reported experience measure, as well as the patient reported outcome measure. It's very difficult to measure value accurately. This is the hot word. If somebody can get this done, it will probably be one of the better way to pay providers. Finally, we talk about comparing the different models. What is the problem? So let's start with cost control. Which model are best for cost control? Fee for service, because there is no cap on how much you can get paid. The cost tends to be the highest. So a lot of systems are facing problems of escalating costs, cost inflation, increase in age specific utilization. So fee for service is generally not recommended for cost control. But provider loves it because it's the most natural. The more I do, the more I get paid. That's the best fee for service. Capitation, very strong cost control. I have a certain budget. You want to get paid more, you need to take care of more patients or more enrollees. Okay, so there's something that the payer loves, but then the risk for the provider is very high because you can end up with one patient that use a lot of care, and that will actually reduce the amount for the others. Salary, not too bad. The issue is whether how do you incentivize the workers to work. In terms of cost control, I think it's not as bad as fee for service. But you can see all around the world, I think even in Australia, there's a negotiation of how to pay doctors in terms of the public sector. But can you really pay providers in a private sector? So unless you nationalize the whole system, the salary is probably only for public sector. Yeah, but for the private sector, they may want to consider paying by salary. That's a way to kind of like control. But if your private sector, your focus is more on productivity, then you really want to consider having some incentives. So again, it cannot be a pure model, but a mixed model. Bundle care, right now you're focusing not just on one. Again, the whole is a negotiated. It covers the whole spectrum of care from inpatient, outpatient, rehab, and so on. Value based, again pay by value. Things that are not of value, things that are over servicing, they are not being paid off. Again, a lot of negotiation, very complex to implement. For quality focus, fee for service is providing a service. Provider may not have a quality metrics. There may be some issues, so that's why you need to have some form of quality control. Otherwise, provider will just see as many patients as they can, and then the quality may not be there. Capitation, I think most of the time they have some predetermined service level agreement, so there's some focus on quality. Salary, again, is medium in between. For bundle care, a lot of times the outcomes, the metrics are all pre-negotiated, so tends to have better quality, and same as value-based. Finally, provider risk. As a provider, I think fee for service salary is probably lower risk. So if I do more, I get paid more. That's very natural. In capitation, if you do more and you come up with some very sick patients, you tend to lose money on the rest. Then you start ration care. That's not a good idea. For bundle care payment, again, the provider risk is high. Why? Because you actually agree to take the whole care. Unless you can provide all the care, otherwise, you need to negotiate with your partners, and these are some of the risks involved. Value-based care, very dangerous. Why? What if the care is not of value? What if the patients have poor comorbidities? So if you do that and you do not take a way to exclude those high-risk patients, the provider may tend to not treat high-risk patients because the outcomes are not there. Then you end up with a form of care rationing. Only the very simple cases get treated and they are paid because the value, the outcome is good. But for those with high risk, nobody want to operate because the risk will be poor. Worst thing, if there's a complication and the payer don't pay, so you're actually doing work for nothing. So provider is very high risk. So in summary, there isn't any best model. So my recommendation is look at your current healthcare system. What is the problem you're facing? Are you facing, for example, high cost? If you're facing high cost, not a bad idea to reconsider fee for service. This is to change the model. For example, in US, cost is a big issue. So you need to really think of, do you want to pay fee for service, everything paid? If you want to pay a fee for service, it's okay. Please have recommended guidelines, set a guidelines, and then the fees will probably go down with time. That's ideal, but provider will say there's inflation. So at least let the fees be controlled. Don't let providers charge as much as they want, otherwise the fee for service will just escalate cost. If quality is a problem, then again, you may need to look at models beyond just paying providers for their services. You look at certain quality aspect, pay for performance, bundle payment, things that actually look at the quality. And finally, if you're talking about making your provider happy, less risk, then maybe you can consider things that are focused on fee for service or quality, because this is the lower risk to the provider.